Of all the forms of inequality, injustice in health is the most shocking and the most inhuman. These words were spoken by Dr. Martin Luther King Jr. on March 25, 1966, in Chicago at a press conference before a speech to the Second Convention of the Medical Committee for Human Rights. And they have echoed across the generations of health science students and professionals who have applied their fields of study to improving the lives of others. My name is Nathan Hankey, and I serve as the Strategy and Workforce Belonging Manager within the Michigan Medicine Office for Health Equity and Inclusion. I am with you all this afternoon in a role as a part of the Health Sciences MLK Committee for this, our 35th annual Health Science MLK Lecture. It is an honor to be a part of the legacy of this event and to kick things off with you today. I want to start by sharing the history of this event, give a brief overview of our afternoon, and then welcome some phenomenal speakers to the stage. The Health Science MLK Lecture was established in 1990, known originally as the Dean's Event. This effort has continued to grow as we bring together the health science schools and disciplines to figure out how we as practitioners continue to add to Dr. King's legacy. This program has evolved over time. Early on, it was a pioneering effort of multidisciplinary and interprofessional partnership, and as that partnership and connection between disciplines grows, so too will the legacy and the impact of our work together. The Health Sciences Committee is comprised of representatives serving on behalf of their deans at our 7 health science schools and colleges, and the hosting of the lecture rotates annually. This year, carrying on the legacy that we received from the School of Social Work, Michigan Medicine and the Medical School, on behalf of our Dean, Dr. Marshall Runge, are proud to host the proceedings today. I am also in front of you today as a representative of a committee full of amazing, talented, and wise individuals that dedicate their time to make this event possible. If you are here in the room or joining us on Zoom, please know that this event would not be possible without your events. If you're here in the space, please raise your hand and be acknowledged. And if everyone would join me in expressing our gratitude for the amazing work of this committee. This afternoon, we'll have 3 phases to the event. Guess what? We've already started the first one. We're in welcome and opening comments. We will hear from our keynote speaker, Dr. David Williams, and then have a wonderful multidisciplinary panel of leaders coming to speak with you today. And then for those who are here in attendance, we will head across the hall in the final phase to spend some time in fellowship, honoring one another and Dr. King's legacy by being in community and recharging with those who are here to continue the work. Before I welcome the speakers to the stage, our first speaker, I'd like to share a little bit more about my role within the Office for Health Equity and Inclusion. Our team is comprised of a group of colleagues that has efforts in pathways to medical and STEM education programs, strategic planning, and initiatives meant to enhance belonging for all who work, learn, and heal at Michigan Medicine. And we have a training program that reaches tens of thousands of people annually. Within that training program, I had the good fortune to be a participant in our History and Race and Racism in Medicine course. And I had a couple of takeaways that I wanted to share today as I revisit the words of Dr. King that I opened our program with. The first is, of course, because it was a history course, never miss the opportunity to go to the primary source. And so I'm going to share a little more context of the quote that Dr. King gave us. And the second is, regardless of how familiar the subject matter is, it's critical for us to reflect and entrench in that thought process so that the lessons learned and the insights gained can seep into our practice and who we are. For many of you in the room and joining us on the live stream, you're familiar with the concepts of the social determinants of health and of health equity. And Today, we have that amazing opportunity to dig into that concept with leaders from multiple disciplines and in the company of colleagues who too care about health equity and justice. And so I invite you to reflect on what motivated you to come into this space, reflect on the relationships you have and will continue to build, and reflect on how those efforts can be an echo of Dr. King's vision for the society we hope to create. With that, I want to go back to that quote and give you the broadest version. This was not a part of his prepared remarks. It was at a press conference prior to advocating for health equity. And he shared, "We are concerned about the constant use of federal funds to support the most notorious expression of segregation. Of all the forms of inequality, injustice in health is the most shocking and the most inhuman because it often results in physical death. I see no alternative to direct action and to creative nonviolence to raise the consciousness of the nation. I hope our time today will raise our consciousness and send us out to engage in actions as a group and as individuals in loud and quiet ways to continue Dr. King's legacy and the legacy of this, the 35th Annual Health Sciences Lecture." I would like to invite our first of many wonderful speakers to the stage. He's a tremendous colleague and leader, and today he will serve as a speaker, a de facto MC, and the moderator for our amazing panel. Please join me in welcoming Dr. David Brown, Associate Vice President and Associate Dean for Health Equity and Inclusion and Professor of Otolaryngology at the UM Medical School. Dr. Brown.
Good afternoon, everyone, and thank you, Nathan. Thank you to the MLK Symposium Committee, and thank you to the OHE staff for all the work that you've done, and thank you all for being here, both in person and virtually. I want to also thank Nathan for setting the stage with such powerful quotes from the Reverend Martin Luther King Jr., and for your thoughtful introduction. Your words remind us of the urgency and the weight of today's conversation. And to me, it's both an honor and a responsibility to address you in this long-standing tradition that we've had here at Michigan, one that unites Michigan medicine with our 7 health sciences schools and colleges in our shared commitment to justice, equity, and progress. Today's lecture comes at a critical time. The Central Campus Dr. MLK Jr. Symposium theme is Restless Dissatisfaction, an urgent call for the pursuit of justice and equality. Hopefully some of you got an opportunity to participate in some of the program earlier today. That speaks directly to the heart of Dr. King's enduring legacy, a legacy that challenges us to confront the structures of injustices in all their forms. Within health and healthcare, this means addressing one of the most pressing and persistent forms of inequality, health inequities that continue to contribute disproportionately to Black, brown, under-resourced, and all marginalized communities. Health equity is not just a concept, it's a moral imperative that underpins our mission here at Michigan Medicine and all our health sciences schools. It calls for intentional, reciprocal partnerships between all of our health systems, our schools and our colleges, and the communities that we serve. These partnerships go beyond academic or clinical engagement. They're about co-creating solutions that empower communities, foster trust, and ultimately deliver better healthcare outcomes for all, high quality care. We all know about COVID-19 and how the pandemic laid bare the devastating consequences of systemic health inequities, from overwhelming our emergency departments and our ICUs to preventable deaths. These realities are not isolated, but they're symptomatic of broader societal failings. And they affect each and every one of us, either directly or indirectly. And Dr. King once said, injustices anywhere is a threat to justice everywhere. And in health and healthcare, this injustice manifests in lives lost, opportunities denied, and futures cut short. At the University of Michigan, we actually have an opportunity and indeed a responsibility to lead in this space. One of the greatest parts about being part of this great university campus and a commitment to diversity, equity, inclusion, and health equity is that we can come together in this way. We can lead, we can educate our future healthcare providers, we can innovate in research, and we can deliver care that is accessible, inclusive, and equitable. If we're not fully committed to health equity, then we're not fully committed to our mission of delivering the highest quality care for all. Let me be clear, health equity is not just a subset of diversity, equity, and inclusion. We know that nationally there's backlash against diversity, equity, and inclusion. And on some of my meetings with Dr. Williams and other people who do health services and health disparities research, we're wondering if we can even talk about healthcare equity, which is quality, which is giving everyone the care that they need to thrive. So it's, our own distinct and essential focus, and one that demands action and accountability for us to deliver this health care equity and health equity. This afternoon, we are privileged to hear from Dr. David R. Williams, a scholar whose groundbreaking work has reshaped how we understand and address health disparities. Dr. Williams is a pioneer in examining the ways that social determinants, including race, socioeconomic status, stress, and systemic racism, affect physical and mental health. His research challenges us to see the connections between justice, equity, and health, and to approach these challenges with urgency and intentionality. Dr. Williams is no stranger to the University of Michigan. As a former faculty member, he left an enduring legacy of scholarship and mentorship that continues to resonate within our community. Now at Harvard University, he has built upon that legacy, leading critical research and developing tools like the Everyday Discrimination Scale, which has become a cornerstone in understanding the impact of racism on health. Today, Dr. Williams will not only share his insights, but also challenge us to think critically about the threats to health equity and how we, as individuals and schools, colleges, and institutions, can drive meaningful change. His work exemplifies the restless dissatisfaction we are called to embody, not as a state of despair, but as a catalyst for progress. As we prepare to hear from Dr. Williams, I encourage you to reflect on how this conversation can inspire action, both within our health sciences disciplines and in the communities we serve. Together, we have the ability and the responsibility to make health equity a reality. Dr. Williams currently serves as the Florence and Laura Norman Professor of Public Health, Professor of African and African American Studies and Sociology at Harvard University. It is now my honor to welcome Dr. Williams to the podium. Thank you very much.
It's truly an honor and privilege to be here with you today and to talk about an important topic of what can we do to reduce inequities in health. And I am using the language of Martin Luther King, the fierce urgency of now. I want to put inequities by race in the United States into a larger context. Drawing here on the work of Steve Wolf that has done a lot of seminal work in this area. The United States is 4% of the world's population. Annually consumes 48% of the world's medical resources, but ranks behind 66 countries in the world on life expectancy, one global indicator of overall health. 20 middle-income countries have better health than the United States does. And I will talk about racial inequities in health today, but whites in the United States do not have an optimal level of health. In fact, they have the worst health among whites in OECD countries. The poorer health of Americans is across dozens of outcomes. And policy seems to matter profoundly. The United States has the highest college tuition rates among OECD countries and the least financial aid. All other OECD countries have universal health care and paid parental leave. The US is wealthy. Number one among OECD countries in concentrated wealth, and number one in poverty. So the inequities there are quite striking. And there are large racial ethnic differences in health in the United States and around the world. Here is infant mortality, deaths of a baby before its first birthday. And you can see African Americans, Native Hawaiians, and other Pacific Islanders, American Indians, Alaska Natives have markedly elevated rates. Rates are slightly higher as well for Latinos compared to that of the white population. Just to show you one other country as an example, here's data for England and Wales, where you can see Pakistani, blacks from Africa, Bangladeshis, blacks from the Caribbean, Indians also have higher rates of infant mortality. So this pattern is not just a US pattern. It is true virtually in every country in Latin America. It's true in South Africa. It's true in New Zealand. It's true in Australia. And the racial inequities in health have existed for a long time. We have data going back to 1950 for blacks and whites. And you can see in 1950, whites had an average life expectancy 8 years longer than that of how do I go back? Okay, yes, 8 years longer than that of whites were 8 years longer than that of African Americans. There's good news in these data. Up through 2010, life expectancy is increasing every decade for blacks and for whites up through 2010. But look at the life expectancy of whites in 1950. And let's ask, how long did it take for African Americans to catch up to the health, the life expectancy that whites had in 1950? 1990, 40 years later, blacks experienced the health that whites experienced back in 1950. And you could see in 2020 the impact of COVID-19 pandemic, that life expectancy declined for both blacks and whites. The decline was larger for African Americans and Latinos and other disadvantaged groups than it was for whites, so that the racial gap was wider in 2020 than it was in 2010. What does it really mean? How do we concretely wrap our head around these racial inequities? Let me give you some ways to think about it. A paper from JAMA in 2023, using the concept of excess deaths. If there were no racial inequities in health, 74,000 black people who die each year would not die. That's 203 black people dying every day. Imagine a fully loaded jumbo jet with 200 passengers and crew on board, and the plane crashing and everybody on board dying. Congress would be moving heaven and earth to find out why this happened every single day of the week and every single day next week and next month. But that's what we're talking about when we say there are racial inequities in health. And there's a lot of evidence that these inequities in health are very costly to the US economy. Estimates of trillions of dollars could be saved in the economy if, in fact, we addressed inequities in health. But let me give you another, Deborah Umberson, putting it in another way demographically. Racial differences in health means that blacks have more deaths of friends and relatives earlier in childhood and throughout the life course. Compared to whites, black children are 3 times as likely to lose a mother by age 10. Black adults are twice as likely to lose a child by age 30 and a spouse by age 60. So we are talking about the loss of social ties earlier and more frequent that affects health across the life course. And yes, we had this powerful statement introduced already. Of all the forms of inequality, Martin Luther King said, injustice in health is the most shocking and most inhumane, and we have tolerated and accepted this for decades. What drives these large racial inequities in health? I was trained at Michigan as a sociologist, And I learned that socioeconomic status, whether measured by income, education, occupational status, or wealth, is a central determinant of virtually the distribution of virtually any desirable resource in society. And race ethnicity is strongly related to socioeconomic status. Here's 2018 data, median household income by race and ethnicity. I'm showing you the same data in a way you can't miss the point. Standardized on the household income of whites is $1. For every dollar of household income white households receive, Asian households receive $1.23. A couple caveats. Asians have the highest levels of college completion. Almost 2/3 of Asians in the United States are immigrants. Asian households also have more likely to be multi-generational, so to have multiple persons contributing to household income. But let's look at the historically disadvantaged groups. For every dollar of household income white households receive, Latino households receive 73 cents, and Native American and African American households receive 59 cents. That's data for 2018. Do you know what is stunning about the 59 cents figure for blacks in 2018? That is identical to the black-white gap in income 40 years earlier, in 1978. 1978 was the peak year of the narrowing of the black-white gap in income as a result of the war on poverty of the 60s and 70s and the civil rights policies of the 60s and 70s. And in 2018, we're exactly where we were in 1978. Have we been stuck at this level since 78? No, it got worse throughout the decade of the 1980s. Reaganomics was not good to the black population. And it was not until 1996 it got back up to 59 cents, and it's a penny up and down since then. The take-home point, we have made a lot less progress in reducing racial inequities, not just in health, but in many other domains than most Americans think. And large racial gaps in income markedly understate the racial gap in economic status, because income captures the flow of resources into the household, but doesn't tell us anything about the economic reserves that can cushion shortfalls of income. We get that from data on wealth. And according to the Federal Reserve Board, for every dollar of wealth that white households have, black households have 10 pennies, and Latino households have 12 pennies. And when you're low in income and low in wealth, we may have all been in the same storm of the pandemic, but we were in different boats. And some boats were better able to weather the storm than others. When my career started, many researchers thought that racial ethnic differences in health were simply a function of racial ethnic differences in socioeconomic status. So if you compared groups across race at the same level of income and education, race would no longer matter. We now know life is more complicated. I'm drawing here on a paper we published many years ago, national data for the United States. Life expectancy at age 25, the average white person lives 5 years longer than the average black person. And for both blacks and whites, the gaps by income and education are larger than the racial gap. So within whites, there's a 6.4-year gap between whites with a college degree and whites who have not finished high school. Within African Americans, a 5.3-year gap. So should we even bother to collect data on race? The economic gaps, income and education, in the interest of time, I'm only showing you education data, is bigger, larger than the racial gap. And why should we still collect data on race? Because race matters at every level of income and education. So if we look at black and white high school dropouts, white high school dropouts live 3.1 years longer than black high school dropouts, and the gap widens as education increases. And remember, folks, this is national data for the United States. The best of blacks, those with a college degree or more education, have lower life expectancy than whites with a college degree, lower life expectancy than whites with some college education, lower life expectancy than whites who have graduated from high school. So what do these data tell us? They tell us there's something about income and education that matters for your health regardless of your race. But there's something else about race that matters even after you've taken income and education into account. And researchers have been looking at the data and identifying what else is it about race that matters so profoundly after we've taken income and education into account. And I've concluded that racism, there's a phenomenon called racism that has consequences for health. What do I mean by racism? I think of racism not primarily individual beliefs and behavior, but as a societal system, a system that categorizes and ranks groups, that devalues and disempowers some, that establishes policies, the system that shape access to opportunity within society. Yes, it can lead to negative attitudes and beliefs, prejudice and stereotypes. It can lead to differential treatment, discrimination by individuals and societal institutions. So first, let's think about the upstream structural mechanisms of racism. This is a paper I wrote years ago when I was here. Racial residential segregation as one mechanism of racism. Policies that shaped access to opportunity, restricted where individuals could live based on their race. John Sell was a historian at Duke University. He wrote a book about the origins of segregation in the US South and in South Africa. He showed that the framers of apartheid in South Africa got the idea of apartheid by looking at how well segregation was working in the US in the late 19th and early 20th century. So when we criticize South Africa, remember, we exported apartheid to them. They called our segregation apartheid. Importantly, Sell argues that segregation was one of the single most successful domestic policies of the 20th century in the United States. And you're saying, what does segregation have to do with anything? Well, think of segregation like a burglar at midnight. It slips into a community, awakens no one, but once it shows up, valuables disappear, like quality schools and safe playgrounds and access to good employment opportunities and a healthy environment and safe housing and high quality transportation and healthcare. Research in the United States reveals that all of these desirable resources vary by your neighborhood, vary by where you live, vary by your zip code. Let's look at some data. William Julius Wilson and Robert Sampson, two of America's eminent sociologists, studied 171 largest cities in the United States and said there's not even, because of segregation, there's not even one city in which whites live under equal conditions to those of blacks. And they concluded the worst urban context in which whites reside is considerably better than the average context of black communities. If you're paying attention, that's a 1995 study. Have things gotten better? No. I'm going to draw here on the work of my colleague, Dolores Acevedo Garcia. She's created an amazing neighborhood opportunity index, ranking every county and then census. You can even get the data now at the census block in her latest version on more than 30 indicators of access to opportunity for kids. And she's looked at the 100 largest metropolitan areas. And she says, which children live in very low and low opportunity neighborhoods? 67% of all black children, 58% of all Latino kids, 53% of all Native American kids reside in very low or low opportunity neighborhoods compared to 1 in 5 white and Asian kids. And you see the opposite end, almost 2/3 of white and Asian kids, and 1 in 5 or less of black and Latino kids live in high and very high opportunity neighborhoods. So place is a powerful predictor of access to opportunity. In fact, research indicates that segregation is the central driver of the large racial ethnic differences in socioeconomic status that we see. Don't take my word for it. Join in the work of 2 Harvard economists. First, David Cutler, national study for the United States looking at young blacks and whites making it in the labor force. He showed statistically, if you could eliminate residential segregation, you'd completely erase black-white differences in income, in education, and in unemployment, and reduce racial differences in single motherhood by 2/3. All of those striking differences are linked to opportunity at the neighborhood level. One more study, one more Harvard economist, Raj Chetty. He's done an intergenerational analysis, got access to not a sample, but census data for multiple decades. And he's asked a simple question. Let me look at black boys and black and white boys who begin life in households with the same level of income. How are the children doing in the next generation? Controlling on parental income. Black boys have lower earnings than white boys in 99% of census tracts in America. 99%. even when you control on household income. Why? They're lazy? No. They're not working hard enough? No. They live in neighborhoods that differ in access to opportunity. Black boys do as well as white boys if they're in neighborhoods with good resources, but that's a very rare event for black boys in America. What do these data tell us? That the racial inequities and socioeconomic status and that matters so profoundly for life and health do not reflect a broken system. No, they reflect a carefully crafted system, functioning as planned, successfully implementing social policies, many of which are rooted in racism. In other words, the inequities we see are not random events. They are not accidents. They reflect the extent to which racism has produced a truly rigged system in the United States. So I've talked about upstream structural mechanisms of racism. There's racism at the individual level that's evident in interpersonal discrimination. And Martin Luther King said that as well, that discrimination is a hellhound that knows that Negroes in every waking moment of their lives declaring that the lie of their inferiority is accepted as a truth in the society dominating them. I developed a number of measures of discrimination when I was here at ISR, working very closely with James Jackson, who I called him the wind beneath my wings as I was doing this important work because such a great supportive colleague. We miss him. But just to illustrate the power of research on discrimination, everyday discrimination doesn't capture all aspects of discrimination, but it captures one domain, little indignities that we don't pay attention to. I'm drawing on the work of Tenney Lewis. Each line on this study represents a published peer-reviewed paper linking everyday discrimination to higher coronary calcification, inflammation, to blood pressure, to lower birth weight in pregnant women, to more rapid declines in cognitive function among the elderly, to poorer sleep, to an independent predictive premature mortality, to a dose-response relationship with visceral fat, shorter telomere lengths. Across the board, discrimination, the evidence today is overwhelming. Today, there are more than 500 published peer-reviewed studies from around the world linking everyday discrimination to, in fact, poor health. And segregation that I talked about not only leads to lack of access to opportunity, but it leads to higher exposure to multiple types of stress. Here's some work we did years ago in Chicago, where we found that for US-born Latinos and for African Americans, they had higher levels of every type of stressful experience we assessed. So they were not only higher on discrimination, but higher on major life events, and on financial stress, and on work stress, and on relationship stress, and on neighborhood stress. And Robert Bullard has shown us of the power of segregation being such a strong predictor of a broad range of environmental exposures that matters profoundly for health and for quality of life. So segregation has a broad range of ripple negative effects on health. And there are hidden ways in which stressors linked to race and racism adversely affect health. I give you one example, drawing on the work of one of my former students, now a professor at Boston University, Jacob Bohr. What we did in this study was linked a database that had every police shooting of an unarmed black person in the United States. And we linked it to a database from CDC with the mental health of the population in every state. And what we found was every police shooting of an unarmed black person in the United States led to worse mental health for the entire black population in the state in which that occurred, and their mental health symptoms were elevated for 3 months. So the entire population, by the way, it was a specific effect. It wasn't every police shooting that produced this result. It was only police shootings of an unarmed black person. If a black person was armed and shot by the police, no negative effect on population health. And we believe it captured the fact that the person was unarmed. It could be you. It could happen to any of your relatives. We are all vulnerable because you don't have to be doing anything wrong for this to, in fact, happen to you. And then there is racism that's built into a culture that leads to stereotypes and that produces discrimination in multiple domains, including the domain of medical care. I served on the committee that produced the Unequal Treatment Report back in 2003 that documented across virtually every therapeutic intervention, minorities, blacks and other minorities receive fewer procedures and poorer quality care than whites. This is compliments of the Washington Post. This is the press conference. At the time, there was a lot of interest in this topic, that there was inequities in the quality of care received in the United States. In the interest of time, I'm going to show you two recent studies. All that has happened last year was 2023. I spoke at two conferences. Where are we 20 years later? You know where we are? A lot more evidence of the problem, not any closer to solutions. I'll give you two studies. A study of 1.8 million hospital births in Florida between 1992 and 2015. When cared for by white doctors, black babies are 3 times more likely than white newborns to die in the hospital. Disparity cut in half when black babies are cared for by a black doctor. Doesn't tell us what the problems are, but it illustrates there's a real problem. Okay, second study, 2023 study. 318,000 patients, all with Medicare, all with advanced cancer in their last weeks of life. Older black and Hispanic patients with advanced cancer less likely than white patients to get opioid medications. When black and Hispanic patients receive opioids, they get lower doses. Black patients were more likely to undergo urine drug testing to see if they're abusing opioids. They're dying of cancer, right? And black men experience the greatest inequality for both opioid access and urine drug testing. We have a problem in these United States. What can we do about the problem? Well, strategy number one is increasing the impact of medical care. First, we need to think of ways in which we can ensure access to care for all. I want to give you one example. Not every problem will be solved in this example I'll give you from the state of Delaware, but the state of Delaware implemented a universal colorectal cancer screening and treatment program that everyone got access to colorectal cancer screening and treatment. The result with the implementation of the program, they eliminated racial disparities in screening. They essentially equalized racial disparities in incidence and new cases, the decline for both racial groups, and a near elimination of the mortality difference. And what was most striking is that the program saved the state of Delaware money. There was a net savings from the program due to reduced incidence and earlier diagnosis of colorectal cancer. Not every health problem can be solved that way. We need to identify those that would work and implement it. What else do we need to do? We need to diversify the workforce to meet the needs of all patients. Randomized controlled trial of 1,300 black men in Northern California, given a coupon to go to a Saturday morning clinic. When they get to the clinic, they're randomized to see a black doctor, see a doctor of a different race. Those men, all black, who saw a black doctor, more likely to talk about other health problems, more likely to do the screening for diabetes, more likely to get the flu vaccine, more likely to do the screening for cholesterol. So greater engagement with the healthcare system. Here is a recent study, 2023, that looked at every county in the United States to see where there were primary care providers, black primary care providers in the county. And they found in counties where there are more primary care black doctors, higher life expectancy for blacks in those counties. We have a huge problem in the United States, the underrepresentation of blacks and Latinos. In 1965, 2.9% of physicians in the US were black. Today, 5% are black, about 6% Latino. We have a long way to go. We need to address implicit bias by clinicians, and not all the solutions may be practical. So here's a study from the UK. One dose, this is a randomized, double-blind, parallel group placebo-controlled study. A single dose of a beta blocker eliminated implicit bias in providers for the next 2 hours. It's wonderful, but we can't medicate the healthcare workforce for the rest of their life. But I think it's an important study. We live in a time where we have key spokespersons telling us that implicit bias is fake news. If we can intervene on it with a pharmacologic agent, This is a real process in the body. It's not fake news, it's real. What is even more discouraging is what our society is doing to reduce implicit bias is not working. Here is a review of over 900 diversity training programs to reduce implicit bias. They raise awareness levels, they can change attitudes towards diversity training, but they do not reduce implicit bias. A review of 400 studies using the implicit association test and other strategies to reduce implicit bias. Same thing. They raise awareness levels, but do not reduce implicit bias. At the same time, there are strategies that have been shown to be effective in reducing implicit bias. I like to point people to what I call the Divine Solution. Professor Patricia Devine at the University of Wisconsin-Madison has shown it is possible to implement a program that markedly reduces implicit bias. It increases awareness of individuals, their concerns. They implement strategies. It's effective in reducing implicit bias. Do you know what's different about what Professor Devine does? It's a 12-week program. You don't change deeply ingrained unconscious processes with a 2-hour workshop. It's a 12-week program with homework exercises. And those who do the homework exercises are more successful in reducing implicit bias. What else do we need to do? We need to deliver care that addresses the social context. And I'm drawing here on a randomized controlled trial from 1978. This is not new knowledge. Len Syme did this study, took 244 low-income hypertensive patients, 80% of them African-American. Randomize them to 3 conditions. 1, routine care. Go to their doctor, get your medication, go on your way home. The second group, in addition to routine care, had to attend a class taught by a health educator for 12 weeks. And the third group, it took lay people from the community, give them 1 month of training, and in addition to routine care, these persons made home visits. They talked about blood pressure, but they were also trained to identify all the resources. They didn't create any new resources, but all the resources that already existed for problems that people face, and they referred people to these resources. And what they found 7 months later, those who were in the outreach group knew twice as much about blood pressure as those in the other 2 groups. And those with more knowledge were more successful in blood pressure control. Those in the outreach group were more compliant taking their blood pressure medication. And blood pressure medication in the outreach group was twice as successful in controlling blood pressure. And they were more likely to have their blood pressure controlled, those in the outreach group, than in the other 2 groups. And we've known this since 1978. We implementing these strategies that would make a difference for improving health. This is a report from the National Academy of Medicine that gives multiple opportunities in which healthcare professionals can address the social needs of patients. We also need strategy number 2, identify the supportive and protective factors and resilience resources that exist. So to give you one example, Gene Brody was doing this study of blacks in 9 rural counties in Georgia. He discovered that those kids who were high on discrimination at age 16, 17, and 18, by age 20, I didn't say age 40, I didn't say age 30, by age 20, there was biological dysregulation, high levels of stress hormones, of blood pressure, of inflammation, of BMI at age 20 linked to discrimination as a teen. However, when they reanalyzed the data, for those kids who were high on good quality relationships with their parents, their teachers, and their peers, there was no relationship between exposure to discrimination and biological dysregulation. One more example, National Study of Black Americans. This is a PRBA study that found higher levels of exposure to discrimination linked to worse mental health among African Americans. But 3 aspects of religious engagement: frequency of attendance, receiving support from others at your places of worship, and seeking religious guidance in your everyday life. Each of these independently reduce the negative effects of exposure to discrimination on their mental health. So the point is, we need to think this is not an exhaustive set of resources, but the kinds of resources that exist that can make a difference. Strategy number 3, we need to create what I call communities of opportunity to minimize, neutralize, and dismantle the systems of racism that create inequities in health. We need to enrich the quality of neighborhood environments, increase economic development in poor areas, improving housing quality and safety of neighborhood environments. All of these are strategies that have been shown to, in fact, improve health. I will elaborate on 2 of them. Investing in early childhood, the Carolina Abecedarian Project. I visited this program in Chapel Hill, North Carolina. They took poor kids at birth and enrolled them in a preschool program. The program is only birth through 5. What did the kids receive? A nurturing environment, good nutrition, good pediatric care. By age 21, it's only birth through 5, and then the program ends. By age 21, those who got the program, better mental health, better physical health, lower drug use, greater academic success, better vocational success. By their mid-30s, lower risk factors of cardiovascular disease and metabolic disease, linked to what those kids experience birth through 5. We have high quality evidence. These are strategies that can make a difference. We also know that simply changing the environment of individuals, improving neighborhood and housing quality with no health intervention leads to improved health. The Move Into Opportunity program was an example of a randomized controlled trial that took residents in poor public housing and just changed, moved them to better housing. 3 years later, better mental health of parents and kids. 10 to 15 years later, lower levels of obesity, lower levels of severe obesity, lower diabetes risk. All we did was change the neighborhoods. And it's a striking example of what's possible. The purpose-built communities model. The East Lake Meadows in Atlanta was a public housing project with African Americans, very disadvantaged context. 90% of families were victim of a felony every year. Only 13% of adults were employed. The local elementary school was one of the worst performing in the state of Georgia. What has happened at East Lake Meadows? Well, I visited several years ago the villages of East Lake, completely transformed. 90% reduction in violent crime, high quality privately managed housing, half the residents at market rate, half the residents qualify for public housing, all able-bodied persons are employed, and the local elementary school where 60% of the kids qualify for reduced spice lunch, so 60% are coming from poor households. The school is one of the top 5 performing in the entire state of Georgia every year. Purpose-built shows it can be done. And you know, the purpose-built society, purpose-built communities, they are providing free technical assistance to any community in the United States who wants to replicate their model. There are at least 30 purpose-built communities approved or up and functioning or in construction in the United States today. My point is, we know what works. We have evidence of what works. And then there's an innovative initiative from a healthcare institution. The Rush University Medical Center in Chicago has shown what is possible. They found striking differences within the neighborhoods that they serve in terms of 14 to 16 year gaps in life expectancy. And they decided to change their mission from a focus on delivering high quality care, that their focus now will be on improving health in the community. They recruited the 5 other healthcare systems in Chicago to join them. They created listening sessions to hear from the community and to commit to shared decision-making with the community. And Rush decided in many communities, the healthcare sector is the largest sector of the economy. And they decided they will use all of their business enterprise to promote community wealth building and economic vitality. They would hire, purchase, invest, and volunteer locally. Focus all the business units on economic activity in poor neighborhoods. Here's a list of some of the strategies they are implementing in terms of ensuring economic development for their neighborhood. What I'm illustrating is we have strategies, we have policies, we have evidence of what works. What's holding us back? What are the barriers we have to address? I think there are three. We need to raise awareness levels. Most Americans don't know that racial inequities exist in the United States. Most Americans are unaware. So we need to raise awareness. Secondly, we need to develop political will so that we will address it. And third, importantly, linked to number two, we need to build empathy. We need to identify how to tell the story of the challenges of the disadvantaged in ways that resonate with the public. W.E.B. Du Bois wrote a book called The Philadelphia Negro. He has a chapter on Negro health. As he came near the chapter on Negro health, discussing the disparities that existed in wards in Philadelphia by race, he said the most difficult social problem in the matter of Negro health is the peculiar attitude of the nation toward the well-being of the race. And he said there are few other cases in the history of civilized people where human suffering has been viewed with such peculiar indifference. What he calls the peculiar indifference, researchers call the empathy gap. We don't care. We don't feel the pain that others are experiencing, and so we can tolerate it. The empathy gap is a real problem we have to address. This is a study that showed at age 5, white children, there is no racial empathy gap. By age 7, there's a tendency. By age 10, it is pronounced. That's what's happening to kids growing up in our society. What else do we need to do? We need to recognize that the policies that will improve health for disadvantaged groups will help all of us. All Americans will benefit from these policies. Creating these communities of opportunity will benefit all. So here's the poverty rates in the United States in 2020. And you could see Native Americans have the highest rate, then comes African Americans, then Latinos, then whites and Asians are the lowest. But if we look at the millions of poor people, there are almost twice as many poor white people as poor black people. So these policies will help all of us in terms of improving outcomes. I do want to end on a personal note. As we look to the future, we need to learn from the past. I am an affirmative action baby. Without a minority fellowship from the University of Michigan that enabled me to come and complete doctoral studies here, I would not be standing here today. This lecture would not have taken place. All my personal hard work and support of family and friends, none of this would have had an impact without that minority fellowship. And it's one thing to open the doors of opportunity. The other step is to provide support. And I received an amazing amount of support from my mentor, Jim House, and from others. This is my dissertation committee. Ron Kessler was the other key player in my career, sat in a T-32 training program that he directed. Walter Allen, another sociologist, he's left Michigan, was at UCLA, that also was on my committee, and then two distinguished public health faculty. Victor Hawthorne was a chair of epidemiology at the time, and Barbara Israel, who was just retired, I think, so I had the greatest committee you could imagine and great support from faculty. But I want to mention, it takes a village. It takes a lot of support to make a difference for individuals. So I want to tell you about 3 African-American scholars, all of them with Michigan connections, who had a huge impact on my career. Dr. Norman Miles did his PhD in history at the University of Michigan, taught at Andrews University in Western Michigan. And I ran into him by chance. I was working as a public health educator in Battle Creek, Michigan. He happened to come to town because his father-in-law was in the hospital where I was working. And he asked me if I was planning to go on to any higher education. I said, yes, I'm planning to do a PhD in sociology. He said, what are you planning to do? Where are you planning to do it? I said, well, University of Michigan has a program, Michigan State has a program, Western Michigan has a program. I'm thinking of going to Western Michigan because it's in Kalamazoo, it's close to Battle Creek, I wouldn't have to move. That was my thinking. He says, absolutely not. You need to go to University of Michigan. Why was I thinking that way? You have to realize when you run into people like me, people talk about first generation college. I was not first generation college. I'm first generation high school. Neither of my parents went to high school. I had no understanding of higher education. I had no understanding of the difference it made where I went to school. I was thinking only of, I wouldn't have to move. A PhD is a PhD. And without his advice, would not have applied to Michigan. And then I'm at Michigan. I'm in my final year. Dr. Alan Morris is one of the assistant professors in the department, one of the great civil rights studies, the civil rights movement. And I'm walking through the hallway in the Ellison building. And Alan said, David, I just got off the phone talking about you. He said, talking about me? About what? He says, oh, someone at Yale called and was asking me who was good coming out of Michigan this year. And I mentioned your name. And I said, Alan, I don't want to go to a place like Yale. That's too much pressure. I just want to go to a nice small school. I can get my research done and get my work done. He said, David, let's go to lunch. And Professor Morris, 2 days later, took me to lunch, explained to me how academia worked. Yes, there may be higher expectations of you. So you come out of Michigan, you'll be high expectations anywhere you go. But why not go to a place that not only has expectations, but have the resources to facilitate your success? And he explained, showed me he had just gotten his first contract for his book. And we would not have gotten it, he said, if he wasn't at Michigan. And so based on that conversation, and a faculty member in my department never took a class with him, but he provided me key advice. So it makes a difference who is in the network that provided the opportunity for me. After that conversation, applied to Yale, got the job, started my career at Yale. And then the third, Dr. James Jackson. When I came back, so I started at Yale, after I got promoted at Yale, came back to Michigan as a faculty, and I wanted to develop these measures of discrimination, mentioned it to James casually one day, and he was, yes, David, let's do it. And I can raise money. We can get a larger sample size. We can do this. He was just the wind beneath my wings. I'm talking about the difference it makes when we invest in young people. Because as I look to the future, I talk about returns on investment. I'm not going to spend time on this. But Michigan can look back and say, yes, there's been an enormous return on the investment of giving me a minority fellowship that has come from it. But really, this is not about me. This is not about me. It's about what are the other David Williams and Mary Williams and Lucy Williams that are out there. What is Michigan doing for that next generation? What are we doing for them? And I want to make another important point before I close. I am an affirmative action baby, but I am well aware that the intent of affirmative action was not envisioned. Yes, I am a descendant of West African slaves, but they were not slaves in the United States. These were slaves in the Dutch Caribbean, my ancestors, and English-speaking Caribbean. And so, yes, I took advantage of affirmative action, but I think I am under even deeper responsibility and obligation because of that. And what are my obligations? I need to actively support, mentor, and do all I can to open the doors of opportunity for African Americans and other disadvantaged groups. I need to confront racism whenever and wherever it emerges, work to dismantle it, reject the Kool-Aid. I want to give you one example of the Kool-Aid. I'm almost out of time. But I have to give you this example. I'm a student at University of Michigan doing my PhD. I'm in Colorado for some weeks in the summer. I run into a white physician. We have wonderful conversations. And somewhere along the line, he discovers that I was a black immigrant. He says, oh, that's why you're studying, why you're in graduate school. He said, because black people from this country are not interested in education. And I said, I'm surprised that you said that because most of my friends back in graduate school are black people from this country. And my success at Michigan was also linked to black people from this country. All the black students and a Hispanic female and an Asian male came together, called ourselves the family, and our motto was, nobody is going to fall through the cracks. And we who are immigrants must reject the Kool-Aid that is often served when we are told we are different. We need to confront racism wherever it emerges. We need to always use our voice, resources, and influence to be on the side of African Americans, Native Americans, and other marginalized groups in this country. I leave you with two quotations. Martin Luther King said, "It may well be that we will have to repent in this generation, not merely for the vitriolic words and the violent actions of the bad people, but for the appalling silence and indifference of the good people. We cannot be silent. We cannot be indifferent. Now is the time for us to go to work. We need redoubled efforts with everything happening in this country today and tomorrow to build a healthier America for all." And finally, I leave you with the words of Robert Kennedy speaking in South Africa back in the 1960s. "Each time a man or woman stands up for an ideal, or acts to improve the lot of others, or strikes out against injustice, he or she sends forth a tiny ripple of hope. And those ripples can build a current which can sweep down the mightiest walls of oppression and resistance." It's my hope that each one of us today would commit to be a tiny ripple of hope. And together, we can sweep down the mighty walls that are growing of oppression and resistance in this country. Thank you so very much today. Thank you.
Dr. Williams, we're going to invite our panelists up, but it's going to be hard to follow up on that amazing talk. So we're going to use Dr. Williams as part of our panel to amplify us. Thank you for sharing of your career, your research, and your journey. Now we are amplified by other members of the University of Michigan Health Sciences Schools. I'm David Brown. I'm the Associate Dean, Associate Vice President for Health Equity and Inclusion. And amongst the many things that Professor Williams shared with us, he talked about community and the impact that different communities can have on our health. And as we introduce each of the panelists, I'm going to ask each of them to answer a question after they give their names and the titles of which are illustrative here. So the pursuit of health equity is impossible without connection to the communities we serve. As part of your introduction as a panelist, we ask that you share where your discipline is at its best in understanding community needs and creating inroads for engagement within the communities you serve. Go left to right.
Hello, everyone. My name is DuBois Bowman, and I serve as Dean of the School of Public Health here at the University of Michigan. I want to start off by thanking Dr. Williams for an incredible talk. Incredible talk. I feel like I was in school. You will hear me reinforce throughout the day many things that he said, because I don't think he left anything out. So really appreciate you, blessing us with your presence here. So, and I also want to do another thing before I answer as well, and that is to acknowledge the reason that we're gathered here today, and that's to commemorate the memory of Dr. Martin Luther King Jr. And I have the distinction of sharing an alma mater with Dr. King, Morehouse College. I know we have some other Morehouse College graduates in the audience. And Morehouse as an institution played an instrumental role under the presidency of Dr. Benjamin Elijah Mays of shaping the values of Dr. King that played out through his lifetime. Dr. King was about the collective. And as I think about public health, by definition, public health is about the collective. So we promote the health of individuals, but also communities, neighborhoods, populations. And it is therefore really impossible to separate that from work with the community if done well. And so we engage at every level with communities. There are various models for doing so. One exemplar for supporting, facilitating, promoting a particular model is the Detroit Urban Research Center, promoting a particular model called community-based participatory research. And that is a model that plays out in research all across our school. And throughout the conversation, I'll comment on several examples, but just to give a few, the Prevention Research Center is one that focuses on communities in the state. Another in the state, feeding Michigan families, and then another focused on migrant farm worker health in Michigan. All of them really, as they go about their work, it's anchored in building those long-term community partnerships and working in co-equal fashions with communities.
Thank you.
So good afternoon. My name is Alfreda Rooks. I'm the Director of Community Health Services at U of M Health Michigan Medicine. And so I can't get away from community because it's in my title. And so I have one of the privileges of working with a very phenomenal group of leaders and folks in community to help us with understanding community needs. And out of my department, we're also responsible for the Community Health Needs Assessment, which was brought about by the Affordable Care Act and mandated that nonprofit hospitals every 3 years have to do a Community Health Needs Assessment, and they have to develop an implementation strategy as well for that. And so we have the responsibility of doing that Community Health Needs Assessment on behalf of University of Michigan Health. We partner with the Trinity Ann Arbor as well as Chelsea Hospital, which is a joint venture between U of M Health, Michigan Medicine, and Trinity, to do that. And one of the reasons why we did was so that we would not all be going back to the same community asking the same questions, and that we could leverage our resources better. And so working with other partners, who I'll talk a little bit more about later, especially from the School of Public Health, we do that community health needs assessment and that implementation strategy. And we listen to the voice of community. So thank you.
Good afternoon, everyone. My name is Olayinka Shinyobola, and I am a professor of clinical pharmacy here at the College of Pharmacy. And I really, again, want to echo what has been said about Dr. Williams' talk. As an immigrant, I really understand what you just said and really resonated with me. In the space of pharmacy, I don't know how many people know this, but 90% of the US population lives within 5 minutes away from a community pharmacy. And one of the things that we do in pharmacy is ensuring equitable access to medications and also medication information. And we can't do that without the communities where these community pharmacists live in. And so it's very critical that we partner with communities in figuring out how exactly can we increase access to prescription medication. How can we ensure that we can provide tailored care? A very critical example that I will share, and an exemplar example, is within the College of Pharmacy, the pharmacist hypertension program that has been done within the college and my colleagues, where pharmacists are able to provide care working with primary care physicians to increase access to blood pressure control for communities. And this is a success story that has been shared now nationwide, and the CDC is now saying a lot of African Americans have high blood pressure and hypertension. How can we expand this within different states within the nation? And this came from Michigan. And even more recently now, working together with communities, now we know that we need to embed pharmacists within tribal centers. And that is a success story that I just come up with colleagues going to tribal communities and saying, what can we do? And that is a success story of pharmacists now embedded within tribal centers.
Great to see everyone. Thank you so much for the invitation, and that was a wonderful conversation. And so much of what you shared in your remarks, Dr. Williams, were about the impacts of public policy, the ways in which public policies can drive inequities, or they can be responsive and help mitigate against inequities. So at the Gerald R. Ford School of Public Policy, that is really core to our mission, to think about the really important role and responsibility that public policy plays in how we exist as a society and how we can assist each other in health and wellness and education and economic outcomes and a whole host of other issues. So that's our overlay in terms of how we think about the work that we do around policy analysis and policy communication and policy leadership, because policy helps to set the rules of the road by which we all have to navigate. So the Ford School is very active in the community. Many of you are no doubt familiar with Poverty Solutions, which is a university-wide center, but really operates out of the Ford School and has deep connections to the community in a whole host of studies that are happening all throughout Michigan, but particularly in a number in southeastern Michigan. We also train a lot of our students, many of whom want to work, yes, at the federal level, but many want to work locally, and many of them want to work at the state level because they recognize the opportunity to shape public policy and to really have that community connection and embeddedness that we are talking about today. So we're really proud of the fact that many of our students have quite diverse interests in how they want to serve, and how our training really helps to respond to that. The other work that we do through other centers throughout the Ford School are really thinking about this opportunity question, whether it's through science and technology, whether it's through educational policy, whether it's through racial justice, whether it's through youth policy more broadly. We're really working very closely with a number of community partners, and our faculty and our students really have the opportunity to hear and to listen and to think about not just how are we offering policy prescriptions from above, but really how are we co-creating policy prescriptions together, and how are we giving people the tools to be able to be policy actors on their own, to be able to speak about the key issues facing their communities and the ways in which policy can be responsive to that. So our work is covering in a multitude of areas to really ensure that we're moving the needle, or trying to move the needle on so much of what we're talking about today.
Thank you. Dr. Williams, you want to, Professor Williams, add anything?
Nothing to add at this point.
Great.
But just that the centrality of community and working with community is so important. Too often we find that academic institutions and academics who enter community don't enter with respect for that community, with an awareness that there's much they can learn from the community and learn of how they can be effective with the community. So I think we've just had wonderful examples from all of my colleagues here.
First question, or second question, and I'll start with Professor Shiambola. How do you engage with and incorporate feedback from the communities you serve to ensure that their needs and concerns are being adequately addressed in your health equity initiatives?
Oh, thank you for that question. We start by doing the work with the community and listening. There's no way we can advance health equity without taking time, and it does take time to engage with the community. And I think as academic researchers and even within the university, sometimes we don't want to do the work. And I think it's important to call, and I think it's a call to action, is we need to take time, be in the community, work with the community, co-design with the community on how we want to advance the work that we do. There is no way we can do the work without them, and taking them alongside. Because sometimes there's always the notion that we need to do something for the community without recognizing that the community has assets. They have a lot of knowledge, they have a lot of strengths that they can bring and teach us on how to do the work we want to do. And when we engage with the community by going in and engaging, then that is the way we can advance the work we do. And then the second thing I would say about that is, after the work is done, come back is another way of engaging. Because sometimes we go and do work in the community and then we're done and then we go away and never bring the data back, never be the science back, never talk about, now we've done all this work, all these trials or whatever we do, and how can we make this sustainable within the community so that the community can say, hey, we have these strengths, now we want to move forward, and working alongside with them at the beginning, like I said, and then at the end, now the data belongs to you because it's about power sharing and giving them the power to be able to make that transformation.
Yeah, thank you. Director Rooks.
So thank you for that. And Dr. Williams, when you were talking, I was thinking about how we engage with community. I have two basic tenets when it comes to us engaging in community. And the first is what you said, listen. And I use the quote, seek first to understand than to be understood. And then the second is to build the relationships before you need them. And I'll give you two examples of that. We have a program that we do that's called Health Cafes. We work with women who are in one of the Ypsilanti Housing Commission properties. We started with women and now we have men who are engaged there too. And it's about health education, health promotion, and wellness. So we went in and we talked to them about, what is it that you're seeing? And they really crafted and designed the way that we were going to put together the health cafes. And so now we're in 2 different properties and we're hoping to be able to expand it. The second example I'll use about how we engage community is a project that came through our anti-racism oversight community work group, and it involved our Ypsilanti Health Center. And during the pandemic, we took the opportunity to have a listening session with a group of African American leaders and activists in community. And the listening session was for all of the leaders at Michigan Medicine, from our Executive Vice President, Dr. Marashall Runge, our Senior Vice President and Chief Environmental, Social, and Governance Officer, Tony Denton, our UMH CEO, President David Miller. And the only caveat that they gave them, what I asked them to do, was to listen. Listen to what people had to say. You could ask clarifying questions, but you could not say anything to defend Michigan. Dr. Brown was there as well. And it was really eye-opening, I think, for the leaders after we had that conversation. And we've kept that going with them. They have become our community forum, so that we can leverage what it is that they told us and make sure that we are behaving in the way and doing what we say. We're walking the walk, just not talking. So it's kind of like put your money where your mouth is. And we did that with our Ypsilanti Health Center. We're expanding that. We brought services into that community, and our new facility will be open sometime in spring of 2025. There were things that they said they needed. They said, why do we have to go all the way to Ann Arbor to get an x-ray done? Why can't we have something in our community? And so in the meantime, while we were working to get that building finished, we purchased a mobile mammography unit with partnership through our Rogo Cancer Center, and we take that mobile unit out to our existing Ypsilanti Health Center for folks to have their mammograms. Now, I'm really excited because once that building opens, I get to have that mobile unit. I got big plans going into the communities where we currently, who don't have those resources. And so it's really important that when you're designing, and my boss is here, some of my best behavior, of course, but it's saying that we do with and not for and not to. I talked about our community health needs assessments, and we take that information back to community so that they can tell us, yes, you were right, no, you were wrong, that's not important to us. And then we fix it, and then we go back to say, this is what we did. So thank you for that.
Thank you. Anyone else?
One of the things that I think is so important as well is when you're able to have these conversations, how your own assumptions get challenged. And for those of us who have been working in the area of racial or gender or class inequities and their impacts on things like healthcare systems, but other structures, we know, or we think we know as experts. But nevertheless, you're still in learning mode, and you're still in the mode where you can have assumptions challenged. So I'll give an example from my work on women living with HIV. Interviewing women in Chicago, I really went in with an assumption that their experiences with the healthcare system were probably going to be negative, right? And we know there's a big literature of that, et cetera. But the number of women who said, I want you to meet my doctor. And you highlighted this so well in your talk of when providers are connected to community, when they're providers of color, when people feel heard, the power of those relationships. So I would interview women and say, and I wonder if you can help me or introduce me to a provider that's meaningful to you, or a person in the service community that's meaningful to you. Really, as I get to know the community of people doing work on HIV, the number of people that said, I can't wait for you to meet my doctor. And the assumption I had versus what women had to say led me to further questions. Well, why was it that women had these connections to their doctors? And it was, further into the scientific inquiry, the way in which the city of Chicago had built a provider community for women living with HIV through decades of work was something that was really important to my research questions, really important to the story I was telling, and actually helped me in the final analysis to understand the full experiences of women living with HIV. So allowing our assumptions to be challenged is also another key piece of that, even for those who have been doing this work for a very, very long time.
Yeah.
The only quick thing I would add, and I think the answers have been terrific, that reflect going in with the right kind of disposition, but also creating the structures and conditions to remove any sense of hierarchy. So including community members in leadership, so a community advisory board or something of that nature, I think can be an effective mechanism to do so.
Thank you. Let's stick with Dean Bowman and ask a question that was alluded to by Professor Shiambola. It's about drive-by research. What are some of the best ways to address the concept of drive-by research? This is the University of Michigan reputation and other institution of showing up in the communities in temporary ways and not coming back. How do we shift this view and become more interconnected within the communities we serve? We'll start with Dean Bowman.
Yeah, it's a great question, and we have to be critical of ourselves in this respect. And it's not a University of Michigan problem. This is something that's reflected across the country. And in fact, I think University of Michigan, as articulated here, has many examples to the contrary. But you have to plant the seeds and cultivate. And the Detroit Urban Research Center will celebrate in 2025 30 years. Right. The Prevention Research Center in 2024 hit the 30-year mark. And so it's really about that long-term commitment and being present, showing up, as mentioned, upon completion of a specific project. That's not the end of the relationship. The partnership should be about more than that. And so I think if you're there, you're present, you're committed to the well-being of the community in a co-equal partnership, then that can protect against that drive-by research phenomenon.
And Director Rooks, I know you have some experience in this as well.
Yes, personal experience dealing with community because we're there. That's one of the things that happens when we're trying to build those new relationships. Well, somebody from U of M came and they did a research project and we never heard anything else about it. And so, you listen to that and you take that. So now what we do, our primary outreach group is a program for multicultural health. And when we have physicians or researchers who come to us to say they want us to connect them to the community, they have to pay a price. And that price is that they have to do a talk around whatever their specialty is, and they can't talk about their research. They talk about what it is that's going to be helpful for that person around that health state or health disease. And then after they've gone out into community with us, that's when the next time they come, they can start talking about their research and what it is that they do and answer questions from community about it. And then after that, the next time they come is when they can start recruiting. Because we want to make sure that they understand that these are people and they are being very vulnerable and sharing with you. And so that comes with a price. And so we've been very successful with that because then people get to really ask a lot of questions that for some researchers, they go back and they've told us, I hadn't thought about it from that perspective. And so now they do. And so I'm really excited about our being able to have that kind of connection, and also to have that trust from both the community and for our faculty around how to engage with community.
Yes. Dean Watkins-Hayes.
I would say also picking up the phone when called and being willing to serve, and through advisory boards, through all kinds of different ways in which members of the community actually would like you to give back and would like you to be present, because that can sometimes help them leverage other opportunities and other resources to be able to say that we have this relationship and we've worked together. So I am still on a number of advisory boards and mentoring relationships and all kinds of things that, and I really see it as a lifetime commitment, where it's a mutual relationship, just like all of our relationships hopefully are mutual, and hopefully all of our relationships are lifetime. So I would say being willing to pick up the phone and, listen to the ask and say, yeah, let me figure out a way that I can be helpful here, or let me figure out how I can connect you to somebody who can be helpful here.
Professor Williams, your talk was about communities and saw numerous studies. What tips do you have for us to share from your experience?
Honestly, I think this group here has shared enormous wisdom and an opportunity in terms of how we relate to community. I remember early in my career being involved in a study and talking to someone in the community, and the person asked me, "Is this a briefcase study?" And I didn't know what the term meant. So I said, "What do you mean by a briefcase study?" A briefcase study is when you researchers come to the community, collect data from us, put it in a briefcase, and then we never see you again. And I think that is what we want to avoid. We want to have meaningful engagement. I think sometimes we are trained and we have the expertise, we have the knowledge, we know the statistical skills, we have the facts, we know what needs to be done, and here are people in the community. We just need to extract relevant data from them, and so that we can make a decision. And so it's really for us to learn, which I think everyone has said, it's approaching the community with respect, recognizing they have expertise too, expertise that we don't have that we could benefit from in terms of working effectively with them, and really finding ways to cooperate with the community and not to come and do research on them, but to collaborate with them in doing work.
Yeah. I'd like to transition, especially that's a question to our two deans. We're fortunate to have two deans on this panel, and you're responsible for advocating for your faculty, for their advancement, and for representing the university. And as a academic university, there's academic rigor. So how do you address the internal tensions around academic rigor, specifically the view that community engagement initiatives are not valued in the same way or seen to be on the same level as other academic pursuits? Dean Watkins-Hayes?
I really do think of this question as a question of audiences. And I do think that we can do work that responds to multiple audiences, both of which, by the way, have standards and expectations. So it's not the case that on the academic side, that's where the standards and expectations and the rigor need to be, and on the community side, not so much. This whole conversation is about that there is an expectation of rigor. There is a set of expectations in terms of how we engage with community partners. So I do think it's possible. And my own work is an example where I do think that you can publish in fantastic outlets and you can contribute to your academic discipline, and you can do work that answers the questions that are of interest to the community. And I do think that we can be ambidextrous in that sense. So I always push back on that tension and the framing of a kind of either or, because I think it can be both and. My latest book got 7 book awards from academic disciplines and my colleagues. And also, I get still calls from members of the community saying, can you sit on this advisory board? Can you advise us on this? Do you want to come to this event and just help us celebrate something? Because we consider you to be a part of our community and the part of the work we do. So I do think that you can have it both ways. And I do think that it's incumbent upon academic leaders to hold up models and to celebrate those models where people have been able to speak to those multiple audiences and pursue excellence with those multiple audiences very, very well. So I think it's important to kind of lift up those models because it is very much possible to do.
Thank you. Dean Bowman.
Yeah, I'd like to actually challenge institutions of higher ed here. And by that, I mean, we see such a demonstrated need in society for institutions of higher ed to do work that's impactful on society. We always have to some degree, but I would argue that there's been a lot of opportunity left on the table. And I think this is a problem that we're seeing playing out in terms of views and attitudes toward higher ed. And so if we want to recruit faculty, position our faculty to thrive doing impactful work that matters to society, then we have to figure out how to reward that work. Right. And so what I'm talking about, the challenge therefore is for our promotion and tenure systems to really truly acknowledge community engagement work, among other things, and understand that, there will be some distinctions. It takes time. We talked about that in the earlier question, and ensuring that that's rewarded so that people who are committed to the work will also have careers that thrive in ways that the work is viewed with respect and rigor.
Thank you. Professor Shiambola, you're one of the newest members of all the panelists. You're one of the newest members to the University of Michigan. Welcome. I think you've been here for about a year.
6 months.
6 months. 6 months. So that we get them involved early. So welcome. And so you may have the freshest eyes on our institution, and you've worked at other institutions as well. What can we do as a university to come together and address health equity in a collaborative, interdisciplinary way? How can we create synergy, mitigate silos, and use our combined perspectives and resources to make health equity impactful?
Yeah, that's a fantastic question. I think it comes from cross-sectorial collaboration. I sort of reflect a little bit on the health in all policies. As someone who's trained as a pharmacist, I can't do the work that I do if I don't reach out to somebody who's at the School of Social Work, because a lot of my work in diabetes is based on peer support, for example. Or as we think about policies to change access to medications, we can do that with individuals who do policy work. And so one of the ways I would say is thinking through how do we reach out and communicate with each other? Maybe it's shared forums, maybe it's an opportunity for us to come together in workshops. And all we are doing is saying, hey, I am from this discipline. I am looking for somebody who can help me energize my work because I want to think a little bit more systemic. Sometimes we need to get out of our clinics and health systems and get out of where we are bubbles and say, hey, I want to reach out to that person. But it also needs to come from the other person willing to come and work with you as well. And so I would say we need to think about other sectors. We need to think about collaboration, shared forums as one way to break those silos. The other thing that I would mention as well is understanding that we all have a shared mission. Everyone, no matter the health science school, at the end of the day, as we are talking today, is about how do we increase equity? How do we advance equity? And we can't do it alone. I like what Dr. Williams said, it takes a village. And everybody needs to recognize that if we sit in our silos, then the systemic issues are not gonna go away. We all need to work together. So I think having that common understanding, having that humility when someone reaches out and say, hey, this is what I want to do because I can't do it alone. And someone saying, you know what, I'll partner with you because we have a shared mission. And then I also think about role optimization as well. When I think about that, is everyone has different roles that we can optimize in getting towards that shared mission. But everyone needs to recognize that they can't optimize their own individual role without interdisciplinary collaboration. And so it comes from a place of humility to do that as well, from the researcher side, to be able to say, you know what, I'm ready to branch out. I want to listen to you because you have a different perspective.
Thank you. I'm going to ask one more question and ask all of you to answer it. Professor Chiambola, you mentioned bubble. Here in Ann Arbor, we live in a bubble. In academia, we live in a bubble. At Harvard, there's a bubble. I was at Harvard. I know what that bubble's like. And yet, our world is changing. The climate is changing. The views on equity, even when it's linked to health equity, is changing. People are concerned about the ability to continue this work and this research. And so, how, considering all that's going on in the world, inside and outside of our bubble, how can we continue to do this work? Anyone?
Okay, I'll start. I think one of the things that's important, especially in the work in community health, the majority of our programs are outward-facing and community embedded. And so we are there, and we're working to look at how the programs and services that we provide around the social determinants of health, and that's everything from food security for homebound adults all the way to immunizations. So we go from age like 5, and I think our oldest client is 104 years old. And so what I try to model for the folks that I work with is that we do this work because it's very important to make sure that all people have access to services. And so I started looking at it from the perspective of, you know, the social drivers of health. And it's not just race, gender identity, ethnicity, it's where you live, whether you have transportation, whether you have access to services. And so we put those things in place to create health for people, and we make it so that it's equally accessible for everyone. We go out into community. We take students with us out into community from the College of Pharmacy, from the School of Nursing, from the medical school, from the School of Public Health, to teach them and help them understand that what we're talking about is a value system. And so we want to make sure that the values that we have around helping people get access to health and better well-being is what we're talking about. And so we do it that way and think about that. So when you come at me for equity, I'm going to say to you, it's one step beyond what you're thinking. Sit down and let's have a conversation.
Thank you.
One of the things we talk about a lot at the Ford School is our ability to have conversations across differences. How can we have meaningful exchanges with people with whom we might not agree, or who have perspectives that are very different from our own, or with whom we might not have had a lot of prior interaction. And as we're talking about community and that importance of listening, the work we do on conversations across differences really expands who our interlocutors are and how we think about that, whether it's where we are in the state and our need to branch out to other areas of the state, whether it is the demographic groups that don't seem to be included in the conversation about who has access to power and who doesn't. And we're not talking about, we're talking about people beyond the folks that we might have been considering before. And we're also all coming back to this idea that all people want opportunities, want chances to thrive, want access to key resources for living. And our job as policymakers in training is to deliver for all, and to think about how you deliver for all. And you can't do that unless you're engaging the broad array of communities that have something to say about this. So we're working on skill building around this area, and we're also modeling it for our students and inviting speakers and staging conversations where students can hear a debate that is reason-informed, and really helpful to understand a different perspective. And I think that in this moment, as we grapple with our bubbles and the implications of not coming out of our bubbles, this piece is really, really important as we think about training our students, but also the work of our faculty in community and how they define who they want to target and how much they want to increasingly branch out and connect.
So to me, I would actually ask the question, how can we not do the work, right? It's so critical and core to our mission. We didn't begin doing the work because it was politically popular. We began doing the work because it's our mission, right? And so if we experience headwinds in society politically, we still don't deviate from our mission. Yes, there might be things that are challenging. Maybe funding is not as plentiful as it has been in the past, but we don't waver from just sort of the core mission of, for me, public health, for other health sciences, things that impact the issue of health equity. And on the bright side, I think about our students, that through challenge, it can be a defining contextual moment for them during their education that might shape them so that they're agents of change well into the future.
Thank you.
I think a lot has already been said, which is no matter the societal challenges that we face, we have a commitment to providing health that is equitable. And it is true, there is going to be challenges in doing it, but there's a lot of strength that people have to be able to wade through the waters to get us to where we are going, irrespective of where we are. And I think channeling the energy that we have into the students, coming together, even with the limited resources that we might have, and yes, there might not be a lot of funding, but there is a lot of community and a lot of strength in that, in coming together to achieve the mission.
Professor Williams.
Yeah, I think we need to remember why we are here, what's our purpose, what are our goals, and the needs exist. I think we are entering an era where much of the language we have used, language of equity and diversity, has now been defined as a bad thing. And I don't think we should let others force us into some boxes that they want to do. I'm not wedded to the terminology. I'm wedded to the work that I'm doing and in making a difference in the lives of others, and try to educate others when we can. There are people who are willing to be educated. There are those who are not willing to be educated. Don't waste time where we are not making progress, but let us not lose sight of the needs that exist that we are trying to address, and be committed as best as we can, minimizing conflict. I don't want to just stimulate conflict for the sake of conflict, but keep focused and keep our eyes on the goal of making a difference in the lives of others.
What an amazing panel. We could sit here for hours and talk. Fortunately, we don't have to just talk about this on one day. We can talk about this every day. Like 4 of the panelists are here at the university. One, hopefully he still has his UMich email address. So we can engage in these conversations throughout the year, not just on one day. This one day just brings us together to catalyze us for the important work to the mission that we're driven to continue. So I want to give a round of applause to all of our amazing panelists. And hope that you have opportunities to have conversation with them during the reception. But before then, I'm going to pass it off to Nathan as we transition to the next part of our program.
You all can stay. We appreciate you very much. Dr. Brown stole one of my lines, but for those that have been joining us through the live stream and those that are here in the room, please help us thank these amazing panelists one more time. We're excited to continue the conversation, continue the time in community, and so shortly we will leave this room. We'll sign off with you all out in Radio Land, but we will move across the hall to spend some time in community. But first, I would like to invite a colleague from our committee up, Ms. Charisse Grice Robinson Lane from the School of Nursing. We heard from multiple disciplines, and this, the 35th annual Health Sciences MLK lecture, was Michigan Medicine's stanza. But this historic event would not be possible if we didn't have cooperation across the health science disciplines and bringing in other disciplines. And so we're excited to offer the first save the date, January 19th, 2026, as we will transition the leadership of the committee to our colleagues in nursing. And so I just wanted to introduce Sharia and allow the mantle to be passed.
Yeah. So I'm Dr. Sharia Robinson Lane over at the School of Nursing, and I look forward to seeing all of you again next year as Nursing hosts our next MLK event. Thank you so much for joining us, and we look forward to continuing the conversation.
Thank you, everyone. Enjoy the rest of your day, and thank you for being here with us.